Assalamu alaikum, everybody. शुरू में आपने आका मौला वास्ते दुआ करी ली है उम्मीद छे ने सगला सी इल्तिमास छे के जोर सी आमीन के जो अपना तबीब रूहानी जे शिफाना देनार छे सैयदना व मौलाना अबू जाफर सादिक आली कदर मुफद्दल सैफुद्दीन आकानी उम्र शरीफ ने क़यामत ना दिन लग दराज दराज ने दराज कर जो मौला ने हमेशा सेहत अने आफियत ना फाखिर लिबास पहनावी राख जो आमीन. Before I start, thank you, Muhammad Bhai, for those kind words. But unfortunately, that's not going to get you off the hook. I do want to thank him sincerely from the bottom of my heart for ruining my holiday in America by dropping a voice note about 4 days ago saying, please prepare a talk for Sunday morning. I really appreciated that, and thank you very much. And I think it's not fair just to single out Muhammad, who's my brother, my other brother, Dr. Mustafa Ali Bhai, who I'm sure you all know, also on the board, was implicit on this plan. We talked about bias and implicit yesterday. Mine's not that technical. Unfortunately, I'm not that clever, but he was also involved in this, and thank you very, very much. And before I start, I must give a shout out to my son, Yusuf, 13. Some of you may have met him yesterday. Unfortunately, he had to fly back to London yesterday because he has to go to school tomorrow. But without him, there was absolutely no way that I could have got this done. But I'm going to say, if it looks underprepared or if I bore you to death, then the hate mail goes to Muhammad and Mustafa. Don't send anything to me in England because it'll be returned to sender. So, but jokes aside, it's an absolute honor and a privilege to be here representing SBMA UK and Europe. I think it's the first time somebody's come in person to talk, and I've heard about LA hospitality, but I can now say I've experienced it firsthand, and it's awesome. I mean, blown away by everybody's muhabbat. Obviously, the food's been exceptional. Unfortunately, the talk yesterday were amazing. I don't know about today. You can make up your own mind about that. But really, really a privilege to be here. And I'm going to hopefully just take you through a few bits of things, hopefully that's new and what you don't know. I'm going to give a very brief overview of SBMA UK and Europe. I'm going to talk about the NHS, the National Health Service. It's UK's healthcare provider. I'm a GP, so I'm going to tell you a little bit of insight into general practice in the UK. Talk a little bit about the differences in prescribing and what we do in the United Kingdom. A couple of pathways that we use in the UK that I think we don't see here in the US. And then I'm going to compare maybe some similarities and some differences between the NHS and the American, obviously, healthcare system that you all know very well. So, very similar to what we heard yesterday in the beginning, at the start of the conference, SBMA UK and Europe, Maulana Ehsan was established by Mufaddal Aka on the 12th of June 2015 in London. It's administered in London under the auspices of Safi Foundation of Europe. Directive aim hato ke medical assistance to Mu'mineen and humanity at large. And I guess that resonates very much with what we're hopefully going to talk about today. Hamna Maulana Ehsan ke just a few weeks ago, a new board was appointed to run for 5 years, which has 10 UK doctors. And this is Maulana's directive. And again, Maulana Ehsan che I'm privileged enough to be one of the board members of SBMA UK and Europe. Some of our activities and initiatives, I mean, it's amazing listening yesterday for the first say half hour, 45 minutes of the conference when you talked about initiatives and aspirations of SBMA America and how similar they are to SBMA UK and Europe. We've had the sharaf of doing Brownrin Mola Ridwanullahi Ziyafat in 2003 in London and 2 Ziyafats of Mufaddal Mola in 2015 and 2021 in London. The Asbaq that is currently running both for doctors and medical students, of which SBMA America, many doctors and medical students are already shamil in that. And then we've been doing a lot of education and research work. I believe in the last conference, Dr. Huzefa Adam Ali, a very good friend and colleague of mine from Bristol, he's a pulmonologist, presented virtually, and he's published things about the global pandemic, low molecular weight heparin, and the halal and haram versions, and all under the banner of SBMA UK and Europe. We run various educational events. We've had a very successful Train the Trainer course, which trained first the physicians and then us rolling out first aid for all London Mu'mineen. And this became really, really useful 3 years ago in London Ashara, when we had a massive pool of Mu'mineen that were already trained in life support. Again, similar to SBM America, we have a very active mentorship program for all our budding doctors and healthcare professionals. And then Dr. Huzefa again is working very closely with Iraq and Bahrain. There are 16 Iraqi students that visit London every year to do work experience. We've had 2 newly qualified doctors that have visited Karbala and have spent time working in Karbala, and that is going to be expanded going forward. And Dr. Huzefa visits and gives as a guest lecturer lectures in Iraq. Local-wise, we try to do a lot of community work, of course, very similar to here. We have clinics in the masjid complex and outside, focuses on preventative medicine, screening. We do vaccination clinics for COVID-19, for flu, for pneumonia. We've had an SBMA conference, which was reflections on the COVID-19 pandemic. We run webinars, and then, of course, support Umur Sehat in various community-based activities. One that springs to mind, just about a month ago, we had a Buzurgono program where we invited them all for Nashto, took them out. I think Baba varamwar farmave che ke apna community nu dhyan rakhwanu to mental health, again, which was discussed yesterday, was important. And I think I've just put that at the bottom. Of course, hopefully just being here is already just the start of SBMA America and SBMA UK and Europe working together. Some of you may be aware, in the COVID pandemic, Dr. Mustafa Bai, working with SBMA UK and Europe, produced an obesity video that was well received by Mu'mineen, and that's just the start. And inshallah, as we go forward, there'll be much, much more collaborative work going forward. Just some pictures of the various activities that we've been running in London. It doesn't work. Sound doesn't work. So obviously it's all about the money. So I think before I going to compare what happens in America and what happens in England, I'm going to ask, just so everybody doesn't fall asleep, this is 2022 data. I want to know what would be the annual spend on healthcare in the US. I want about 5. So Mohammed, I'll come to you first. The spend, either you can do it per patient, per person, or total annual spend that the US spent. 500 billion. Dr. Najmuddin? 2 trillion. 1.5 to 2 trillion. One of the ladies, anybody? Batul? 10 million, okay. So I think nobody was close. So, well, actually you were, 2 trillion you said. So 2022, $4.5 trillion, which worked out as $13,493 per person. Just for, I mean, probably don't understand what I'm saying anyway, but I've converted all the pounds into UK, into dollars, just to make it easy. So UK, Moise, bye. $7 per person. Wow, man. You need to come over to England. $7, that's pretty good. That's quite close. So total amount or per person? Could I get some shout out, anybody? Amir? What would you say the UK spend in a year, in 2022, total? $4,000 per person. Amir? 500 million. Zabi, AB, you've got a UK connection. What do you reckon? $1 billion. So it's $239 billion, which is 5,139 per person. So it was $4,261 billion less spent in the UK in 2022. But who would you say is considered the better healthcare system? Obviously, I'm from England, but I don't know. Canada, yeah, okay. Canada did rank higher, actually, but I'm just comparing UK and US. Let's see. Who would you say? Perception is US, but reality is UK. Does anybody disagree? US is better. Anybody else? If you have the means. Okay. So in UK is better. Obviously, I have to say that. The Commonwealth Fund, I back it up with just some random thing that I found on AI, but the Commonwealth Fund in 2021, don't look up this AI because I think, no, I'm just kidding. 2021 ranked UK out of 11 developed countries, UK ranked 4th out of 11. Unfortunately, US came in at 11. I'm not here to get like you throwing stones at me or something when we finish, but basically, it was a higher life expectancy in the UK and lower maternal mortality rates. And I think that's important when I talk through some of the differences in the system and why, you know, somebody said at the back about the means. I think that's really important. So before I start, I thought I might just take you a little bit on a bit of a journey just to make it a bit more interesting. I'm sure you all know Doris, your 70-year-old grandma. She comes to you on Monday morning, 9 a.m., 70-year-old. She's got severe abdominal pain. She's in the UK. What is she going to do? What are her options in the UK? So number one would be a GP. So that's a general practitioner. That's what I do. I think here you call it family practitioner. Slightly different to internal medicine, but I'll talk you through a little bit of the differences. So she could come in, make a same-day appointment on that Monday morning with her general practitioner, somebody like me. I could assess her, think she's okay, arrange some outpatient investigations, maybe some blood tests, maybe an ultrasound. Nothing's really going to happen that day. I may give her a prescription, send her on her way, and hope she doesn't keel over on the way back home. I could also refer her to hospital, speak to the team on call. She would be admitted, should have inpatient investigation. It will be done on the day, at the time, and have the treatment then and there. She could call 111. 111 is a unique health line that works in the United Kingdom. It is supposed to be for when GPs are closed, and I'll talk about the opening times, but it is basically a healthcare advice line. You can call anytime. She could call 111. She would have a phone call assessment, again, by a healthcare professional. They could arrange a GP appointment. They plug into the GP surgeries in the area. They could arrange an ambulance to visit her at home, assess her, take her into the hospital, or they could even arrange a GP to go and visit her at home and do that assessment if she didn't have the means to access health care. Okay, she didn't want to do that. 999, or I should say 911, emergency services. She could call them. I think that's pretty much standard everywhere. They would do a triage on the phone. They'd send either a paramedic to her house who would assess her, or an ambulance to convey her into the nearest A&E, I should say, or ER. The last thing she could do is herself go to A&E. So she could ask a friend or a family member to take her, or she could just make her own way and present to A&E. So all of these services that I've mentioned would be covered under the NHS. They're available to everybody in the UK 24/7. And the NHS itself, the conception was during World War II, and it was launched 5th of July 1948. 3 core principles, and I think a lot of this resonates with what we were talking about yesterday when we were talking about equality. It's free at the point of delivery. I think that's one of the most important things that sometimes people fail to understand. It is free at the point of delivery. It is based on clinical need and not the ability to pay. Somebody said right at the beginning, in the US, if you have the means, you're going to do much better. The idea in the UK, it's for everybody. And universality. It covers the entire population, meeting the needs of everybody. Now, clearly that's going to have issues, but those were the 3 core principles that are still active today. Who is entitled to the NHS? An ordinary resident of the UK is entitled to free treatment. This is regardless of your nationality, regardless of whether you pay taxes, you are entitled. Every single person. Ordinarily resident is a little bit of a now tricky term. It has been abused. Healthcare tourism was massive in the UK. People would come over, heavily pregnant, deliver, get a British passport and go away for free. And they've stopped a lot of that. If you visit ER, A&E now, they have a little office as soon as you enter overseas. They want to know when you've come, what your status is, and they will now start sending you bills for treatment if you are not entitled. So how do they fund it? I thought it was just useful just to show, I don't know the US taxation system, but basically the core funding comes from general taxation. And you'll see that anybody earning over £50,000, so $60,000, will pay 40% tax, and anybody over about $150,000 will pay 45% tax, irrespective of where you live. That's in general income tax. So that is where the funding comes from. There is a smaller amount of funding that comes from national insurance contributions that employees and employers will always pay, but that's what it's for. So let's not forget about Doris. She saw me, her GP. She had some right upper quadrant pain. I referred her to the surgical team on call with suspected acute cholecystitis. She went to hospital. She had an ultrasound. She had a CT, confirmed the diagnosis. She had IV antibiotics. She didn't get better, so she had an emergency inpatient surgery. All of this, again, was done as an NHS, no cost. And I think you'd all agree if she had been here, she didn't have, even with the best insurance, there would be some sort of cost enacted to Doris. So general practice in the UK. First point of contact for all patients with any health concerns. We treat all ages. So that's, I think, a key difference between internal medicine here. We'll see kids, we'll see pregnant ladies, we'll see gynecology, we'll do a bit of everything. We then refer to NHS services and specialties. Core GP hours are between 8 and 6:30. Now the NHS has created a contract which is Monday to Sunday, 8 to 8, but outside of core hours, generally that's outsourced to out of hours. And what we'd do, I just thought I'd give a summary. I would say quite a lot. There's quite a lot of things similar, I'm sure, to what physicians would do here. So my own surgery, so just to give an idea, it's a multidisciplinary team approach now. I think that was less so when I started. We have 16,000 patients. So everybody registers in your local area with your general practitioner. We have 10 full-time GPs, practice nurses, healthcare assistants. We have in-house pharmacists, physios, PAs, social prescribers, care coordinators, mental health practitioners, all working in my own clinic, appointments for my patients accessible between the core hours. So how are GPs paid? I thought I'd just give you a little snapshot of how we're paid. So it's a practice level funding. It doesn't come as an individual GP. It comes to the practice, and there are 3 core income streams. Patient-based funding. So I mentioned I've got 16,000 patients. You get a set amount of money for every patient that's on your books. I think the difference in America is the more punters you see, the more money you make. I don't want to see anybody, because if they're already on my books, I'm already getting paid for them. So the more I see, the more hard it is for me. There's no extra money that's attached to that. Then there is quality incentive payment. So if you reach specific clinical targets, a blood pressure reading in range, you will get more. An HbA1c of a good controlled diabetic, again, that's more money that generates for the practice. And then locally enhanced services. For example, an annual diabetes review, an annual COPD review. All of these are enhanced services that are worked locally and will vary from place to place. And I think yesterday, I think it was discussed about postcode lottery in the US and healthcare. It is similar in the UK. GPs are their own bosses, they have their own practice, and they vary massively. Mine's a large practice. Down the road, there's a single-handed guy who has 2,000 patients who just on his own runs his clinic. The healthcare you will get and you can access makes a huge difference. So I'll introduce you just to Jim very briefly. He's Doris's husband, and he has diabetes, COPD, hypertension. He has a bit of dementia. So I get a fixed payment for Jim being registered with the practice. His BP is well controlled, so I'll get a quality incentive additional payment at the end of the year. He comes into the surgery to have his blood test. That'll be an enhanced service that I'll get paid for. And then I book him in with the nurse for a diabetes, COPD, dementia review. Then he'll see me afterwards. All of that will then be claimed as additional money for work. Just 2 last points before I finish. I think I'm almost out of time, and then we hopefully have a little 5 minutes for some discussion. Prescribing in the UK is massively different. Pharma I see everywhere. Every commercial I've seen, advert, we say on the television is about all these drugs. You don't see that in England. And we do pay a prescription charge under the NHS for anybody over 18 and up to the age of 60. So children and in full-time education don't pay, and that's $13. That's regardless of the drug. So I could be prescribing amoxicillin, which costs 10p, or Humira, which costs $2,500. But I've just given a few examples of the difference in the price of drugs that you can buy in the UK and you can buy in America. And I think that's a huge difference here, marketing the branded, where we generally prescribe as generic. 2-week rule is just one last system, which is a system to get patients with cancer seen very quickly. I think it's an amazing system because everybody is accessing healthcare. Here, you would refer immediately. Somebody came to see you with abdominal pain, PR bleeding, it will be easy to arrange a colonoscopy. It's not so simple to do that in the UK. So you have a specific 2-week rule pathway for every sort of where cancer could come. And as long as you tick those boxes of those symptoms, as I mentioned, abdominal pain, PR bleeding, new onset dysphagia, a breast lump, postmenopausal bleeding, the specialist has to see that patient within 2 weeks, and they are seen and treated, and that pathway runs brilliantly. So let's just summarize at the end. So funding, obviously in America, is primarily through private insurance. And in England, private insurance is coming up because I've mentioned about how it works in the UK, and the problem then happens is there isn't enough funding. So you will wait. I'll see somebody today who needs an inguinal hernia repair. They may wait 6 months to see the general surgeon. He will then put them on the list, and they will wait another 3, maybe 6 months before their operation. Same with a knee or hip replacement. Here, maybe you don't even need the hernia, and you already had the surgery done. So the difference is the funding access is there. So the private system, which is almost identical to UK, is now coming in to America, is now coming into the UK. So people are buying insurance, they will self-fund for the non-urgent things. But I feel very strongly that if you're in the UK and you have a serious health condition or cancer, people ask me all the time, should I go private? Even if they've got insurance, I will say stay within the NHS. I feel the care you receive is incredible. And so I think just maybe something to discuss, or if we've got, I don't know if we've got time for any questions, but how should the healthcare systems evolve going forward? We've seen in America, I think, and it's been a privilege to be here and talk to you all, about the Obama Act or the Affordable Healthcare Act, and how that's already impacting people and getting healthcare out. I think that is very similar to the NHS or providing better insurance coverage, but how we should evolve that with the English system coming towards a private-based system and now people investing in that, and here going towards an insurance or an Affordable Healthcare Act that does provide free healthcare to the masses. Maybe something in between is where we are. So I think that's thank you, and I don't know if we've got time, but happy to take any questions if needed.
Can you walk us through your day as a GP? You're there for about 8.5 hours, I think, or 9.5 hours. How many patients would you see? How many telehealth? How many in-person?
So I think that's a really good question. I think that's changed massively since COVID. So pre-COVID, general practice was a face-to-face organization.
I'm just going to repeat the question.
Sorry.
So Dr. Amir asked about, can you go through your daily routine, how many patients you see, and he's going to give us a summary of that.
So, as I mentioned, pre-COVID, everything was face-to-face. I think COVID has changed it massively, where we all learn how to do remote consultations, I think video, phone. So my day mix would be you'd start surgery at 8 a.m. as soon as the surgery opens. In England, on average, you get 10 minutes per patient in general practice, and you'd probably do a 3-hour surgery. So you'd see about 18 to 20 people, maybe with a few extras. The screaming kid with the earache or sore throat, or the worried mum would get added on. Generally, kids are not turned away. You'd then break, and your afternoon time would be generally where you would look at the lab results that have come in that day, or the document letters that consultants like yourselves have seen in the hospital and written back to us with their opinion or things to action. Please prescribe this, please arrange that. Home visits are still prevalent in England, would go and visit the patient at home, particularly for palliative care. And then you would then go into your afternoon surgery, typically kick off for around 2:30 to 3, and that would run till about 6, 6:15. You'd see another maybe 15 to 16, maybe 17 patients again. What my surgery does, we have a duty doctor. So we have one person who's on call who would see all the on-the-day stuff. So I would see mostly pre-bookable patients booked about a week in advance that want to see me for their routine health care. They would see this acute sore throat, the cough, the lower respiratory tract infection. So that would be a typical day of what we would do.
Alibai, thank you for reminding me how great the UK is. Having worked in both systems, I think I mostly agree that sort of primary care is really excellent in the UK. The one difference I think is probably better here. Don't tell my mum I said that, but access to subspecialty care, I think especially in pediatrics. So my question to you is, how do you manage the kind of referral to subspecialty care, and what does that look like?
Yeah, really good question, I think. And I think that is the challenge. So as a GP, I'm very happy with my team of doctors that work for me or with me. And we do pediatric training. So, as Mohammed Bhai said in the beginning, I was a surgical trainee, went into general practice. And before I did that, I did obs and gynae intentionally because I had no clue about any of that. And a huge bulk of our work is that. And then pediatrics. So here, everybody sees a pediatrician immediately. We see all the kids first and then deem who needs to be referred. And the real challenge is the time delay, especially post-COVID. So it is a real challenge, and patients will blame us. So they will be ringing the GP every single day. Everything. My appointment hasn't come through. Why haven't I got my appointment? There's not much more I can do. I've sort of reached as much as I can do for that patient. And that, I think, is the bottleneck, where you see here, hurt my ankle, let's have an MRI, let's see the number 2 ranked orthopedic, Moy's number 1, aren't you? So the number 1 ranked orthopedic surgeon in the whole state of America, or just New York? America. Okay, so you see the number 1 rated surgeon, he's given, and it's all done within half an hour. In England, I mean, it's maybe a good and a bad thing. Your ankle is better by the time you've got your hospital appointment. So you don't need to go anymore because you've cured it. So it's a difficult system, but by making it more multi, I mean, I'm a mental health practitioner. Obviously, we all talked about it yesterday. Mental health is prevalent everywhere. We've intentionally gone out and employed somebody who works just seeing that. And, they get half an hour to try and unpick something. I think 10 minutes, I don't know if you know 10 minutes, I mean, I've been talking for way too long already, but 10 minutes is a short space of time. For me, I've got no kit. So I've got a blood pressure machine, maybe an horoscope, a stethoscope, that's it. And you've got to make an assessment. And you know what it's like. The culture in America is much worse, but people will blame you. So I hope that answers a little bit of what you said. I don't know if we've got time for any more, but...
Ali Bhai.
Sorry.
Ali Bhai, shukran. So just to kind of make it a little bit more interesting, one of the criticisms that we've heard, especially when there was all this press about Obamacare and the similarities with the NHS, was it's very hard to get new drugs and new procedures adopted within the NHS. Is that true? And can you speak about that?
So I think there is an element of truth in that. I would say I wouldn't be a world expert or be able to speak, because mostly my work is in primary care, but of course I have an understanding. And, just a recent example, I was reading just before I came about a new breakthrough drug for Alzheimer's that is already being used in America, and the NHS deemed it was not a cost-effective option for the masses in the UK. Now, clearly that could help and save people or improve their quality of life. The NHS felt it wasn't. Most of those things are available in the private sector in the UK. So, yes, not accessible for everybody. And I think, again, accessing that is the very difficult part. But I would disagree that a lot of the breakthrough work in the centres that are tertiary referral in the UK, the Royal Marsden is, I'm very fortunate to be very close to that. It's a cancer hospital that is doing clinical trials that are equivalent to what is happening in America. So I do agree, yes, there's probably an element of that. But I think on the really, really serious and important things, the NHS is now much more focused on that research as well.
I was just curious. So one of the things that I think in America kind of drives most healthcare providers insane is the constant like back and forth paperwork, phone calls with insurance companies to try like what we feel like we know is best for the patient. You're arguing with people back and forth all the time, and it's a huge one, time suck, but then two, it just becomes like mentally exhausting and is a huge problem in terms of like what I've seen burnout for physicians, because they just feel like they're always fighting against somebody. Do you ever encounter those issues with the NHS, or is it really a different culture of if a doctor kind of thinks this is what we want to do, it's generally readily accepted?
So I think I think it's an amazing point, and I think our battle is more what we would like to do, and similar to your point, whether the NHS can support that as fully as we like. So it's not an insurance company base, but it does ultimately come down to money and funding. Everybody knows that the NHS is a bottomless pit. Every new government, we've just had a new government too, they're pumping money in, everybody pledges more money to the NHS. In my opinion, it's a bottomless pit. To save it is very, very difficult. So the challenge, I think, is that delay in getting the treatment that we think they would benefit. And I think, don't get me wrong, I said emergency care, somebody's having a heart attack, somebody's having a stroke, they'll put them on the table, they'll put a stent in within 20 minutes. They'll have them in a CT or MRI scanner and thrombolize them within, 2 minutes. That's all done. But the general things that can wait a little bit end up waiting quite a lot longer. And I think it's not fair for me to come up here and say it's a bed of roses and we're living in a wonderful system. To get a GP appointment is a challenge sometimes. To get an appointment with a specialist, and that's probably the challenge that we face. Okay. Thank you very much. Thank you. Hope you could understand what I was saying. Thank you.